Hi, everyone. Thank you for joining us. We are very excited. We've been touring the country doing a lot of HRT talks for women. And then so we decided we should also cross the pond and start talking about men because they aren't talked about enough in medicine, apparently.
Much simpler topic.
Yes.
Still more complicated than people project, but much simpler, of course. So we're going to try to squeeze this into an hour. We have so much material that this is not an hour's lecture. And so we've had to pare it down again and again and again. This is strictly about lab testing and testosterone. So it's going to seem like some of our explanations are maybe a little truncated or incomplete. That's just by necessity. Couple of admin points before we get into the material. Number one, of course, if you're an ND, testosterone is not within our scope of practice. And so any reference to TRT is just for educational purposes. Our learning objectives today are to understand testosterone testing options, lab thresholds, and to go over a couple of patient cases. We'll start with physiology. Where it's made, very simply, testosterone is 95%. 95% of testosterone production in a man is from the testes. There's about 5%, even less than 5% that comes from the adrenals. And then there's peripheral conversion of the precursors. That would be DHEA to androstenedione to testosterone. Most important first step in understanding testosterone, I think, is to understand the differences between total testosterone, free testosterone, bioavailable testosterone. The best way to understand this is to imagine that testosterone is like a pizza. So let's go over here for a second. All of our steroid hormones are made in the smooth endoplasmic reticulum. They largely come from cortisol, from cholesterol. Apologies for some of these are kind of junky graphics. We haven't had time, but what's important is here.
What's important is the pizza.
The pizza, yeah. Stay focused on the pizza. So total testosterone is the big yellow box here. As you can see, 95% of it is made in the testes, 5% is made in the adrenals. So now we're talking about the total pool of testosterone in the blood. And that total, you can imagine like a total number of pizzas in a Whole Foods. Okay, the Whole Foods is the big yellow box. Most of the pizzas in any Whole Foods are bound, they're in the freezer. They're bound to SHBG in testosterone's case, tightly bound to SHBG, meaning that they're inedible. They're frozen, they're not active. That's the majority of our testosterone that's floating in the blood is like that. And there's then a lesser portion that is either in the oven, hot and ready, almost kind of hot and ready to go. That's 30 to 55% of our testosterone. And then when it's a hot and ready to go single slice, that's like your free testosterone, which only makes up about 1 to 2, usually 2 to 3% of our total testosterone. And there's method behind that. It's strange to say, well, you have all this testosterone and 98% of it is bound to something and only 2% of it is completely free. But evolution is smarter than we are. So it designed these mechanisms to buffer between the extremes so that we don't have 100% in the freezer or 100% ready to go, because that's a very inefficient Whole Foods. And so like any restaurant, you have sort of a chain of use, a chain of readiness of any kind of good. And that's going to be 40 to 60% in the freezer, SHBG, 30 to 55% in the oven, bound to albumin, weakly bound to albumin, almost ready to eat. And then the free testosterone, which is 1 to 2% ready to eat. In other words, ready to hit the androgen receptor.
Oh my God, that's so cute.
Okay. Little Pac-Man.
Pac-Man.
Junky slides, but, but it gets the point across. Okay. Genetics are huge. There's a lot of misunderstandings about testosterone. And this is one of the questions that people don't seem to ask is how much of my testosterone is genetically mediated? And it's actually arguably a majority. In men, there are studies showing that there's variation. The genetic factors accounting for the testosterone level variations are 40 to 70% in men and 65% in women. And so there's strong heritability for serum testosterone. 99%. I don't know that I have ever had a patient where I've asked them, hey, what was your dad's testosterone? Mm-hmm. Nobody tested testosterone decades ago.
Except people still don't. So we still don't have an appreciation for it.
in general practice, for a general workup, for prevention, for curiosity, for optimization, nobody tested testosterone. And so nobody really knows what their dad's testosterone levels were. But there's a huge genetic contribution. Whose labs are these? Would you guess that these are Bobby's?
Oh.
Or are these a bodybuilder's labs? You'd see a total testosterone of 26.2, a free calculated testosterone of 581, a bioavailable of 13.8. That seems like a very high testosterone. This must be a huge, well-muscled, manly man stomping around.
Hi.
But it's actually Bobby's testosterone. Bobby, I don't know if you can tell, is not a bodybuilder.
Yeah.
This is his testosterone level. It's a 26. And the body actually here belongs to Ben Pakulski, who in contrast, he's retired at 43, but he's still built like a house. He's a big guy. And he feels great at a testosterone that's lower than Bobby's. And he's got way more muscle, way bigger. He's this accomplished bodybuilder.
I mean, I feel great too.
Bobby feels great.
I don't look like that.
Bobby looks great.
I feel great too.
But they don't look the same.
No.
You can't just say, oh, high testosterone must be a big, huge guy the size of a house. Doesn't work that way.
We want to sort of dismantle that and decouple the idea that physique, even in treatment, even in who to treat, that we need to like see beyond the book cover here for sure, in both extremes.
And that gets at how there's so many myths to testosterone. There's so many oversimplifications. The reality is much more nuanced. The reality is paradoxical in a lot of cases. It's not sort of this linear set of attributes that we project onto it, where somebody with low testosterone immediately is this guy, and it's because of the low testosterone, and somebody with high testosterone is this guy. Way oversimplified. There's a million myths. There's a really good book about this called The Virility Paradox. Highly recommended to read if you're interested in testosterone or you treat men. And of course, they'll be inquiring about testosterone, to dismantle some of these myths, because they just abound left, right, center.
Because there's also not just about labs and like ranges with references and treating a number on paper. There's a philosophy here too. I think that's what we're trying to say. There's a philosophy around how do we attach judgment towards what we're seeing on paper.
So what's average testosterone? Average, of course, it peaks in younger men, 18 to 20 years old, usually is approximately the peak. That's at about 16 nanomole per liter. That's the red line here. And then between 40 to 70 years old for total testosterone, surprisingly, total testosterone doesn't change that much over a lifetime. It largely stays steady over the years until you get to 79 years old, according to EMAS, a study that we're basing this on. And so total testosterone peaks roughly 16, then stays at about 13 for a man's life, and it itself doesn't actually drop. However, there's a difference between, as we got into with the pizzas, between the total testosterone, the total number of pizzas, including the freezer and the oven and the bound, and the free testosterone pizza slice, and that can be assessed using the bioavailable testosterone test in LifeLabs. You'll see on the LifeLabs rec that there's testosterone. That implies total testosterone, so total number of pizzas in the whole foods. And there's bioavailable testosterone, and bioavailable includes total testosterone and SHBG, and a bioavailable testosterone that's based on an albumin of 43 grams per liter. It's calculated. And then from that, free testosterone is derived. It's not a direct measurement, as we'll get to in a minute, but it's a calculation of the above. So when you see this on your lab rec, you have two options of less expensive, but just cursory total testosterone, or you have the bioavailable testosterone, which gets you all of these metrics. Do you want to speak to either of these?
Well, I kind of just want to say that when we're looking at what in naturopathic medicine, because I believe most of us, if not all of us, are naturopaths watching, in naturopathic medicine, we think we should do the more expansive tests, the more like it gives us more information. And that isn't true here. Like testosterone itself covers the vast majority of people. And you'll see, we made a lovely little graphic to help show that. But bioavailable testosterone helps in certain instances, but just because it has more information doesn't mean that that information is actually more meaningful or more valuable just because it's identifying the pizza slices. Sometimes the Whole Foods is good enough to identify what the actual problem is.
Yeah, great. When we're looking at bioavailable testosterone, you'll notice that there's no albumin that's reported in the printout, because we're not actually using the patient's albumin when we're reporting their bioavailable testosterone. Rather, we're using a norm. We're using 43 grams per liter as an average albumin. This is one of the arguments, or one of the caveats of using bioavailable testosterone, is there's some imprecision. There's some not imprecision. There's a bit of variance.
There's assumptions.
There's assumptions built into it, because you're calculating the free testosterone, not measuring it directly when you're doing bioavailable testosterone, and that requires some assumptions. You have to assume what the albumin is.
The range of albumin is between 35 and 50. And so 43 is the average number used in the calculus. But what if somebody is closer to 50? What if somebody is closer to 35? That's why these numbers aren't as reflective of the person in front of you if you're using a BAT.
More on that? I feel like that's...
No, move on.
Okay.
We'll get to that later.
On the, how I was saying that total testosterone doesn't really change over a lifetime. This is reflected by this view as well, that over the years, over the decades, you can see here, this is the 40s, the 50s, the 60s, the 70s, and total testosterone largely stays the same. These three lines are stratified by BMI. So the people that are the leanest tend to have the higher testosterone baselines throughout their lives. People who have a higher BMI, particularly in cases of obesity, their total testosterone is lower as a base, and so that's standard for them over the years and decades, unless their body composition changes. So total testosterone is largely flat across the years, and you can see that free testosterone, however, does decrease. There's a couple of reasons for that free testosterone decreasing. The main one is that SHBG tends to go up as we get older, naturally, evolutionary. In every group, lean or overweight, there tends to be a rise in SHBG. There's a couple of reasons for this. When you're young, testosterone across all species, is meant to encourage mating competition, territorial defense, physical fitness, aggression. It's a reproductive hormone. It's meant to get your genes to the next generation, and aggressively so. But the older we get, you don't want grandpa being aggressively trying to get his genes to the next generation, both for two reasons. Number one is, if grandpa's being physically aggressive, he's going to get injured. And number two, the three reasons, I guess. Number one is he'll get physically injured. Number two is that grandpa should be supporting the tribe, the genes that are already passed on. And then number three, grandpa's genes are not as good as DNA isn't as fresh. And so there's three reasons why evolution has made it. Grandpa's SHBG is way higher. His freezers are way more to bind that testosterone, so he doesn't keep trying to get his genes onto the next generation, and that's left to younger members of the tribe. So this is all inherently, it's a brilliant sort of thing. But when you have a 40, 50, 60, 70-year-old guy coming in saying, I don't quite feel the same as I did before. Look, my testosterone is going down. My free testosterone is going down. How do we force this back to the way that it was when I was 20 years old? I want to have the testosterone of a 20-year-old. Well, you're fighting evolution. And so you can do that. There's pros and cons. But in doing that, you're taking on risks that evolution is trying to not have you take, because this is what's given rise to our species being as stable and as solid, and our communities being what they are.
And this question is coming up all the time now, which is why this is such a topical thing, that men of any age are now asking for longevity. They want to live their longest. They want to live their most virile. They want to live their most healthy life. And they think it's associated with something like keeping their testosterone levels high until they die. And yes, there's some aggressive grandpas out there that are sort of like role models and win elections. But like maybe we don't need to necessarily encourage that to be the case for everybody, especially when it has nothing to do with their health outcomes.
And there's trade-offs. So there's pros and cons. Of course, drop your body fat, be healthy, drop your inflammation. We'll get into a whole bunch of things underlying testosterone levels and how they might change for the worse. But to just, shift your testosterone back to the way it was in your 20s and 30s you're taking risks.
I have another thing to say about this, actually, because the BMI is, we have 3 cases. One of them involves this, but I want to touch on it now. I say this every time. I might sound like a broken record for some of the people who have seen me speak before, but BMIs are not the be all and end all across different demographics. So Black people have a very different health risk and outcomes, different BMI than white people do, than South Asian people do, than East Asian people do. So these are general graphs for the general population, but they don't account for the specific BMI changes. Like an example is, and people like me and Indian people, our BMI needs to be much lower to make sure that insulin resistance isn't having the impact on testosterone than it is on somebody else, as you would see in this graph.
Factors that, do we have that? No. Okay, we're skipping factors A for now. Too much to cover. Let's get into lab testing.
So one of the things that is an issue is that there's so many different guidelines, so many different authorities, bodies who say testosterone should be this, or there are online companies that say, like, actually, we think that testosterone should be this, much higher before we start to trigger a prescription for it. And it's very confusing for both patients and for clinicians. One of the reasons is because there's no real standardization across the board. Here's an example of how wild the normal reference ranges are between different groups. This is in Europe. That assay methods are different, calibration of machines is different, standardization is different. The population that they're working in with, where they live, that they're getting the reference range from is different. Like I just said, what if it's different in India than it is in Ethiopia than it is in New York? We have different diurnal variations where all the standards we need to have to measure the purest form of testosterone, fasting, within 3 hours of waking, before 10 a.m., depending on what age you are, all of that, like the number of factors that increase the likelihood of variability is huge. So that's why it seems chaotic. We've tried to distill this all down, as you'll see in one of our graphics, but this just shows how much of a tornado it is and why it's so confusing.
One of the main differentiators is what sort of methods is that lab using to assess their testosterone, to output testosterone levels. There are 2 main ways of testing testosterone. There's immunoassay and there's mass spec. Immunoassay is effectively, you have a light bulb that sticks an antibody that's sort of like a
it's not a light bulb.
It's not a light bulb.
It's not a
you have an antibody that can give off light, that sticks to an antibody that sticks to testosterone. So you've got this kind of chain of ants. LifeLabs uses this one. It's commonly used. It's economic to use it. It's quite accurate. And then the alternative is mass spectrometry. Mass spectrometry is gold standard for research. It's more expensive. It's more finicky. It overlaps very significantly with IA. And so you're not missing out by not using mass spec. But mass spec is to blow up the molecule and map the fireworks. Gold standard, expensive, uncommon. And there's tighter variance when it comes to mass spec. Mass spec has a 6% variance coefficient, and immunoassay has a 10 to 19%. LifeLabs tends to be on the tighter end of this. So we toured LifeLabs in Burnaby. That was really cool. We hung out with Joanna Jung at LifeLabs in Victoria. We asked her about this, saying, here's what we're reading by the American Urological Association latest guidelines on lab testing, and they're saying IA is 10 to 19%. And she said, oh no, our levels are quite a bit more consistent. We're closer to the lower end of that range, the tighter end of that range.
I mean, she literally said, like, LifeLabs would never tolerate that high of a variance. Mm-hmm. But that just goes to show you another example of a specific lab who has a very different way of measuring this than what we're typically seeing sort of in general guidelines.
But still, wherever you're getting tested, a general rule of thumb is then you need at least 20% change from pre-testosterone to post-testosterone between after your intervention to know that your intervention has made any difference. And so when you test somebody, and you'll see this in our case, one of our cases, really well laid out, is if testosterone went up 10%, that's nothing. You can't say that you did anything there. That's lab variance.
Yeah, do you guys remember the whole concept in osteoporosis and DEXAs, that when you measure a DEXA, you have this thing called a least significant change, that 2 to 4 years later, you have to be 4% higher than the error of a DEXA, which is 4%. Otherwise, a bisphosphonate, whatever you used, didn't do anything. Oh, good, it's a 2.5 and it went down to a 2.4. It's like, that's the same number. Same thing here.
And that's pretty much the same for mass spec too. If you're seeing a 10% change, don't hang your hat on that.
Another comment about mass spec, like you'll see in guidelines and research that is the gold standard. But gold standard doesn't mean realistic. Labs do not tend to have that, in Canada especially, as an option for like community clinicians to use.
Outside of research, there's basically what we're saying is there's no benefit of mass spec over IA. So LifeLabs is what we use. It's very good. It's reliable. So when you see this, don't think that you need to go find a lab that does mass spec and pay double. You're going to get the same outcome. You're going to get the same results. Okay.
Where are we? Oh, so a comment though, that they're using the same idea that when you're trying to find the least significant change, if you end up going above 20%, great, you did something. But look, when you actually decrease somebody's testosterone who is at a normal range, like they're in the normal range in the middle tertile, and if for argument's sake, as this particular study suggests, if you cut it in half, you would find that they end up being now hypogonadal. If you did the same for somebody who's increased in the upper tertile and you decreased it by 50%, you would see that they're now still normal. But that might not mean normal for them. And it also means that we have to do repeat measurements to find out what the truth is, because serial measurements need to be done in testosterone because there's so much variability, both in the test itself, but also in the patient's behavior around getting the test. And that's why we need multiple tests to be able to capture the truest number. And usually in medicine, we decide that the lower number, like the worst number, is the one that we're trusting. In the case of testosterone, it would be strange for a hypogonadal person, truly a hypogonadal person, to have a normal testosterone level. So you typically trust the higher number to tell you if there's a discordant result, that maybe it's actually not a testosterone issue. Maybe I should focus on the other things happening with this person, if there are other things happening with this person, before I start really encouraging TRT.
So broadly speaking, if they're on the upper half of normal, are they somebody who's hypogonadal? Less likely. Are they on the lower half of normal? Maybe, but even then it depends. We're going to get into an algorithm here, but their highest number is the real one when you're retesting, because it shows they have the capacity of having that testosterone level. Whatever got in the way on the day that they happen to have the lower one is maybe not as accurate for what their testosterone production level is.
What are we saying here?
This sort of speaks to the same thing, that if you are going to do a trial, you want to bring people up into the upper tertile. 17 to 20 is the recommended level by Up to Date in 2024. If you're over 20, you don't need to be that high. You can reduce the dose according to the existent literature to date. Of course, this may change. This may continue to evolve, but based on what expert opinion is, it seems like 17 to 20 is the place to aim for when you're intervening on testosterone, to at least get somebody who's an 8 up to 17 to 20.
So there's a problem here in that a lot of now practitioners are thinking on this longevity train, and that they're trying to push the testosterone into the 20s and even start diagnosing men below 20 as having low T, and then saying like, of course you're going to be tired, but like this may be something completely different that's related to their symptom. Or if they're asymptomatic and they just want to like live forever, that doesn't fit with the evidence that we have to date from all of the expert guidelines. And so I want to make sure that we are conscious of the fact that the evidence is saying around 17 to 20 is an aim. That isn't necessarily diagnostic for low testosterone. That's the aim of when you're using something to make you make more testosterone or give you testosterone. And so we don't have to aim for the stars here. That's good enough to get rid of symptoms in the vast majority of men who are hypogonadal.
A lot of these direct-to-consumer testosterone therapy platforms are overdosing men on the promise, on the mythology that, oh, this will fix all of your problems. Oh, your testosterone's a 19. Oh, yeah, that's low. Let's bring you up. That's not medicine. This is marketing. And as you'll see in our cases, there's actually slim odds of a benefit if your testosterone is that high to begin with to push it higher in terms of pathologies, in terms of signs and symptoms.
So the specific signs and symptoms that suggest that this person in front of you, this patient, is more likely to be worked up for and have low testosterone are low libido, decreased morning erections, loss of body hair, like actual physical body hair going away. It almost looks like an alopecia, low bone mineral density, gynecomastia, and small testes. Those are very specific for low testosterone. The least specific things, meaning the things that are probably due to something else, are fatigue, depression, but I feel like we don't think like that, right? We think of a man in his 40s and 50s who comes in and says, I'm so tired. Why am I so tired? Or I have low mood. And we're like, we should test your testosterone. It's like, actually, we should test all the things, not just your testosterone. Add testosterone, especially if some of the more specific symptoms are showing up too. And if performance, like reduced muscle strength, like I'm not as strong as I used to be. Yeah, because you're 15 years older than you used to be. And that's actually a perception more than it is actually true. Like some of the studies that we've read are, it's a perception of a reduced muscle strength rather than actual like grip strength changes that are unlinked to the person's age. Increased fat mass and anemia. Those are less justifiable for thinking testosterone. It doesn't mean you don't think of testosterone. It's probably something else.
Likewise with libido, it's normal for your libido in your 40s not to be what it was in your 20s. That's, like I said, evolutionarily built in. And so some of this requires a conversation with the patients and an assessment of how distressing is it to them, how bothersome, do they just not know that this is normal? And don't beat yourself up about it, don't worry about it. Or if they're really distressed, it's affecting their relationship, it's affecting their sense of self. And despite knowing that this is normal for a 40 or 50-year-old, there's a problem. Let's say that they're not getting morning erections. Then certainly worth looking up what their testosterone is, working it up, and then that would more justify treatment than just a vague sense of 40-year-old midlife depression.
Yeah, there's a difference between low libido and lower libido. Lower is what Paul's talking about. Low is like, I just actually don't have any interest. Totally different.
So what if you have somebody on a testosterone supporting therapy and their symptoms don't improve? Then you should question, after 3 to 6 months, you should question whether testosterone deficiency is really the etiology of their symptoms, because there's no utility in continuing TRT in men who have achieved target testosterone levels, but their symptoms haven't really changed. Keep in mind, there's also the placebo effect. Men starts to inject within the first, or inject or take anything orally, or take a supplement, whatever the intervention is going to be. And for the first month or two, they might be, oh yeah, I think I feel better. And if month number 6, they're back in your office saying, still have that fatigue. I still feel kind of depressed.
When I learned that my testosterone is the level of a bodybuilder, I didn't do anything differently, but I felt like I never need to sleep again. I'm going to use everything I got. I had so much more energy. I was like, oh my God, I feel like a gorilla. But nothing changed other than my perception of my own results. And the only reason I did that was because I was just like, oh, I'm interested in what this is. I'm 44 years old. Let me see. And then when I saw the result, I was like, Jesus Christ.
Yeah.
Let's go.
Yeah. The number of guys who come into our office and it's almost like a horoscope, or it's like tea leaf reading. You tell them you have high testosterone, and the man immediately puffs up in his chair. You can see his sense of self improve. You can see his confidence, and he just feels like, yeah, that fits. That sits right with me. And then likewise, you tell a man on the lower end, he might come in with his chest up and feeling good, and he's accomplished, and he looks well muscled,
and he feels great.
But then you tell him, your testosterone's actually like a 12, which is like fine.
Popping a balloon.
It's 12, 13 kind of thing. And then his shoulders shrink, and he immediately,
he gets deflated.
He takes on the identity of how this guy might feel. And so there's so much mythology here.
So there are 2 exceptions. The definition of the diagnosis of hypogonadism and is you need to have symptoms. It can't just be that you have low testosterone. There are absolutely cutoffs that suggest something's very wrong, but in the demographic we're talking about, of sort of in the lower range, maybe in the middle range, maybe has something going on, but they're not quite sure, you need to have symptoms. And if the symptoms don't change, like Paul said, you're on the wrong path. It could maybe be something else as a diagnosis, or maybe it's just this person's lifestyle. Who knows? But that has two exceptions. Patients who have documented bone mineral density loss. So if they have osteopenia or osteoporosis, you keep them on their therapy because their low testosterone is influencing their bone mass. And patients with unexplained anemia, testosterone is involved with hemoglobin synthesis through erythropoiesis. And if they have unexplained anemia, it's not because they're celiac, it's not because they have some other kind of dyscrasia, and their testosterone is low, and that improves on TRT, then you keep them on it because that's going to prevent them from having the erythropoiesis going down in the future.
So direct to consumer testosterone therapy platforms will just have an often we've poked around and we've sort of gotten a glimpse behind the curtain of a lot of these platforms, and they have an arbitrary number chosen, like 20, where they just give everybody who has a 19 or less testosterone therapy. That's not evidence-based. That's not what the
in fact,
guidelines
they're
say.
not even sure about it as they're saying it. They have like
right.
they have an insecurity about it as they're saying.
Mm-hmm. So they're not evidence-based. They may be ahead of the curve. There may be 20 years from now the way that we'll practice medicine, but to date, they're not respecting what the literature is saying on testosterone levels. So for this, we go to the American Urological Association. This is based on their 2024 paper. We made it into a really simple graph that's kind of an algorithm in and of itself. And so you have a man that comes into your office, for whatever reason you suspect hypogonadism, you run total testosterone. Now what?
So I read this from the testosterone result first. So 0 to, can I see your cursor?
Sure, yeah.
Okay, 0 to 20.
Okay, so that's the base, the x-axis there.
So you ran the testosterone, it came up less than 8. And so you can see the red bar goes from 0 to 8. And if you now know they're not producing testosterone in the way that they should be, because anything less than 8 is pretty diagnostic, you have to figure out whether or not they have something going on. The urgent and important things are, do they have a pituitary issue? You measure their prolactin. If their prolactin is off or elevated, you have to do an MRI or refer for an MRI of their brain. You can refer for karyotyping. You can question whether or not they're actually previously took testosterone, and that's the reason now they're in a trough with their blood test. Whether they had a testicular injury and they're actually just physically not able to produce it. So you have to find out whether or not those are part of this case. If that workup happens and you deprioritize retesting until you know that those are all okay, then you can confirm that their testosterone is actually low, again, weeks or maybe a month or two later. And then you can say, there's still less than 8. I'm going to help them now with the testosterone specifically. If they're between an 8 and 12, this is that sort of range. Anything above 12, guidelines and evidence doesn't suggest that we should do anything with these people, but there's caveats to that. But if they're between an 8 and a 12, you have to correct what other things may be presenting in this person. They may be suppressed with their testosterone, like their insulin resistance. They may be overweight. They may have a big tummy. They might have actual diabetes. Maybe they know that. Maybe you're just figuring that out too. Maybe they're infected. Maybe their thyroid is off. It's too low. All of those things are suppressive of our own testosterone production. It doesn't mean that you have hypogonadism. It just means that something else is influencing your body's ability to produce that. So fix that thing, which will quite likely fix the testosterone. And if it doesn't, or if at the same time they are really interested in wanting their testosterone to rise to help them along their way with their weight loss, with their energy, whatever it is, you can do that. But the point is, fix the underlying condition, then retest, and quite likely their testosterone is going to normalize.
Dysglycemia, insulin resistance, these are so common. And so you can't just skip that they have hypothyroidism and I'm going to jack up their testosterone and they're diabetic and let's just juice them up with testosterone. You have to fix that correcting underlying reason why their testosterone is low. And so you might work on their blood sugar level. You'll find that a few months later, their testosterone, once they're well controlled, their diabetes is controlled, or they're more insulin sensitive, then their total testosterone naturally has floated up and you haven't put them on any intervention. That's naturopathic medicine there at the root. Find out what's actually underlying, what's at the core of their issue, remove that, everything else should work better. And so that's exactly the case in this. And sorry that these are offset. It should be that the red is here, the blue is here, and the gray is here. So ignore that this top bar is sort of not in line with the bottom ones. I just realized we did that. But you have to correct the underlying issues. And if their testosterone is an 8 to 12, you've corrected these, or like Bobby said, in tandem with correcting these. You retest testosterone, you know that it's in the 8 to 12 range. Yep, for sure. Then treatment often helps in that range. And again, you're aiming then for 17 to 20 for a total testosterone after 3 to 6 months to reassess and see if that's helped.
But what happens when their testosterone is above 12?
That last category, if their testosterone is above 12, but they have symptoms, or they're over 60, hypocaloric, they're on various medications that raise SHBG, they have any hyperestrogen sort of indication, these might be a reason for SHBG being high and sequestering their total testosterone, making the free testosterone be something that you now want to get into knowing. And so in that case, if they're testosterone of 13, but they have low libido and ED and small testicles, then you might say, let's look at what your free testosterone looks like. And then that would be an assessment as the bioavailable testosterone. You check the BAT box. And then in that case, let's say you reconfirm that, yep, their total testosterone is low, their free testosterone is low within the range. Likewise, treatment even still is unlikely to help at a total testosterone above 12, according to the evidence, the latest best evidence in 2024. But if their symptoms indicate that it's worth a trial, it's safe and it's indicated in that case to do a trial to get them at least 17 to 20 and then see how they feel 3 to 6 months later.
And this is one of the reasons why I said earlier, like using a BAT right off the bat is not necessary. You have a very specific group that you can use this for rather than universally using it. And this helps to understand like the flaws in the test, but also the flaws in people that we need to understand a little bit better information about that person by then adding another piece of like another data point, like a free testosterone. So you see that it's more an exception than it is anything.
So ultimately the question then is, we've got all these arbitrary cutoffs, and then we've got medical decision limits. How do you know what you should be diagnosing and treating based on? Is it reference ranges? So the lowest 2.5% only, the lowest 5%, the lowest 10%. Is it medical decision limits? And how do you know if those are valid? If you're on one end, the direct to consumer testing companies, you're in it maybe more for the financial gain than you are practicing medicine. And so how do we make that judgment? And this is that same study that showed over a lifetime testosterone doesn't really change. Total testosterone doesn't really change. And it shows the standard deviations around that average. And so where should the cutoff be? Should it be that everybody outside of red is treated on the lower end, everybody outside of blue, everybody who's green, or only the purples? That's sort of philosophical, and that's really evidence is yet to weigh in on that.
It's the doctor's dilemma. What do you do with the human being sitting in front of you, asking you to help them with their problems? That's the medical decision limit here, right? Like you have to be able to clinically decide whether or not this is a path you wanting to go down that may not necessarily do anything for this person after poking them, prodding them, reassessing them for 6 months, a year. It's confusing.
Likewise, we're only talking about the lower people that are below whatever cutoff, below average. What if somebody has too high of a testosterone? Are you worried about bringing them down? And is that the top 2.5%, the top 5, the top 10 medical cutoffs? That is not going to be covered today. That's a whole other discussion of what too high testosterone is, what's causing it, what you should do about it. If it's natural or unnatural that they got there, endogenous or exogenous, I should say, that's not going to be covered here. So let's get into the cases.
Okay. This is a patient of ours. Paul and I have a group practice, so we see a lot of patients together, or they'll see me and him, and then they'll see the next one for their follow-ups. That's the way we like it. This is LS, a web developer in his 50s. He has insulin resistance on previous lab tests. He's on metformin as a result of that. And his main symptoms that he wanted to have help with were erectile dysfunction, lower libido, and fatigue. So we ran his labs. You can see here that his fasting sugars were an 8.5. So it looks like this man has diabetes now and he's on metformin, remember. His fasting insulin is higher than we like for it to see. So the combo between the two is quite high. His estradiol, his luteinizing hormone look okay, but his testosterone looks like it is in the actual pits. You can see that this person, according to what we just said, should have almost an automatic referral for an MRI because, oh my God, this man isn't producing any testosterone at all. His luteinizing hormone suggests that there isn't really maybe anything happening with his pituitary, but what's going on here? His free calculated, bioavailable, they're all in the pits, including his SHBG. But then you see his CRP is 151. So you question, wait a minute, what was going on with this person when they had their blood test at the lab? And I really like this case, and I really like our cases because it is so important for us to know. The reason we do multiple tests on people is because what if they had a cold? They went to the lab, and unbeknownst to them, the cold they had last week or the symptoms they have from a cold that aren't specifically, like, they're not bothered by them, but it is going to affect their labs. This patient ended up saying that they actually had a cold.
So we gave him a lab rec, sent him back, and then here's what turned up a couple weeks later.
Yeah, so you can see his testosterone has gone up. Has it normalized? Probably not. But has it gone up from the pituitary?
Normalized to his baseline.
Yeah. Do we have to do a pituitary tumor-seeking MRI? No. He had a cold. Is his diabetes? Does he have actual diabetes, or was that just him having an infection and his body going through it and the inflammation associated with it? And we can see his CRP went from 151 to 0. So now we're getting a better reflection of who this person is outside of being unwell.
So he came back in the red category. We're like, that's weird. He doesn't have any symptoms that would suggest, or any history that would suggest any other reason. Oh yeah, right. He then said that he was sick. Let's send him back. And then it came back in the blue zone. So now blue zone, the blue zones.
Mm-hmm.
I need breakfast. So then we decided to go ahead and give him treatment. Okay. Now in terms of the treatment.
So this is a lab lecture, right? And we have 15 minutes left. So there's a lab lecture. So don't think about, we're not going to talk about too much about our treatments. We're not talking about HCG. We prescribe it. We prescribe Ozempic and other GLPs. We prescribe tadalafil. So we gave this person treatment. Ignore that for now. What's important is that after we gave this person treatment at a testosterone level of 8.4, his testosterone rose to 24.1, treated the insulin resistance, treated the things that were showing up for this person. His other testosterone markers rose as well, and this person felt amazing.
Testosterone went up. Everything was great. So we'll cover these in depth in a different lecture. Case number 2, AB. AB was a professional dart player. He's vegetarian, no comorbidities. His body fat is a little bit higher than we'd want it to be. Some symptoms that came up in the last couple of years for him are changes in energy, mood, libido.
Oh, okay. This is my favorite. So, remember in school, maybe that was a long time ago for some of you, like it was for me, or it was recent. I believe, overemphasized questionnaires for people. Anytime somebody comes in, you give them a questionnaire. If they come in with like a rash on their head, you give them a questionnaire. If they come in with being sad, they give them a questionnaire. And some of these questionnaires are validated. But just because we use good anxiety and depression questionnaires doesn't make all questionnaires effective at understanding what's happening with the person. So the ADAM questionnaire, I think, is what most people are used to in Canada. There's also called the Androtest questionnaire. They are not great. So if a person actually has hypogonadism, they don't really capture it as well as lab testing does. A questionnaire should never inform you to have not done a blood test on that person. It'd be like, oh no, he answered no to everything. He should be fine. It's like, no, you still have to appropriately assess this person beyond the questionnaire. If the questionnaire is like, this person absolutely answered yes to everything, now you're just confirming they have symptoms of hypogonadism. So that you would have tested it anyway with that person because they're telling you they have those problems. The sensitivity and the specificity are important here. The specificity of an ADAM questionnaire for identifying hypogonadism is 39%. For an androtest is 65%. We look for 90% or higher to know that something is has good specificity. They're terrible, and they should be de-emphasized.
Back to our case, when I first graduated 7 or so years ago now, I was really strongly about the therapeutic order, and you have to start with the psychology and knowledge and understanding and work up through habits and environment and then natural interventions. Then finally, when you
Probably like
those,
most people here.
Yeah, most people. And it's intuitive to an extent to think that way. We all want to be treated with learning and knowledge and natural means before we jump to a pharmaceutical. It makes sense. But I didn't test that assumption. And so for years, I built this whole testosterone guide and program for guys to go through where we'd work one step at a time through these levels. And then coming into practice and doing a lot more testosterone and learning about the evidence, literature around testosterone, I realized that this is the case of philosophy overriding evidence-based medicine. And so I've pitched this. I don't no longer practice this way. But we applied this to this person's case because he was game for the experimentation. He wanted to learn. He wanted to know. He was all in on this kind of philosophy. And so you'll see the next several slides are us unraveling, us sort of displaying the folly of following philosophy over an evidence-based approach.
So like this particular patient was happy and interested in having us understand different therapeutics and the therapeutic order in what happens to them on paper.
So we got a baseline from him. For a baseline, you always want it to be fasted at least 8 to 10 hours. So he fasted as of 10 p.m. It was a morning blood draw, 8 a.m. Testosterone peaks in the morning within 2 to 3 hours of waking. And so for most people, we'll tell them fast at 10 p.m., go to the LifeLabs between 7 to 9 a.m., 7 to 10 a.m. at the latest. And then it was a typical day, perfect conditions,
something.
Well slept, no sickness.
I like the way you answer this question. Mm-hmm. So a lot of research is suggesting that men over 45, men over 50 don't need to have their first morning testosterone tested. Why is that not the case?
So testosterone for everybody spikes in the morning within the first couple of hours, and then it levels off, and it can be 40% lower in the afternoon. This disparity is more marked in younger men. And so younger men tend to have a higher peak, and then they drop significantly into the afternoon. The older we get past 40, 50, 60, our peak is blunted. And so it kind of comes up and then just sort of stays there for the whole day. There's less of a spike drop. And so regardless, if you have a 50-year-old and you're like, well, no problem, I don't need the peak because he doesn't really have one, you're still going to retest the testosterone if it comes back low anyway. So for everybody, regardless if they're in your office, it's 2 p.m., you want to draw their blood, send them to the lab, send them back, bring them back another day, but get it in the morning for everybody, all ages, because that'll save you an extra step.
Guilty as charged. I had a bad habit of if a man who was over 45 years old came into my office at 3 p.m., I would be like, oh, we should test your testosterone, knowing that the likelihood of you being peaked or the variance being lower for you throughout the day suggests that your testosterone might be the same at 3 p.m. that it would be at 8 a.m. Until he got a hold of me.
And that's reasonable, but then you have to rerun it. You have to rerun it again in the morning anyway.
So because I knew that I'm retesting it anyway. I can do the first draw, but then I saw that I wasn't doing two equal tests, even though the literature suggests that you can and you probably can get away with it. You just don't know with that specific man if you're getting away with it. Our testosterone drops from between 8 and 8:30 in a lot of people. It drops 50% in a half an hour. It's still at its highest point in the day, but it drops significantly. Anyway, I really wanted you to say that.
Yeah, great. So first thing in the morning, fasted. And his testosterone baseline was an 11, total testosterone. Weeks 1 to 2, we went all in on psychology. So act as if you have high testosterone, meditate for your stress management. We've all heard about cortisol and testosterone. It's all cortisol's fault, and you have to manage your stress. Okay, great. Acutely, after 2 weeks of doing that, it made zero difference. There's this 10.4 total testosterone. Weeks 3 to 4, we've all heard, okay, you got to lift weights, and you got to eat high protein, and you got to get to the gym, and you got to be consistent with your health habits. Okay, great. So we had him lift heavy 3 times a week. That was the big 4 lifts. We had him take in at least 100 grams a day of protein. We sent him an article about the 31 testosterone raising foods to see if those would make a difference in 2 weeks. Nope.
And
9.6.
these were all wildly different than what this person had previously been doing in their life, right? It wasn't like they were already heavy lifting like this. This is wildly different.
Yeah. So he did those for 2 weeks. No change. Still around 10. Weeks 5 to 6, we did all the darlings of the naturopathic world. Oh, vitamin D. You definitely got to optimize your vitamin D linked to testosterone. Whole sidebar on this, that vitamin D is not causative for testosterone levels. It's correlated to testosterone levels. If you imagine a guy who has low testosterone, who is feeling crummy, stays indoors, doesn't go out much, he's not getting much vitamin D. He's not physically active. He doesn't feel good. So he's let's say he's in the basement playing Dungeons and Dragons, eating chips, because he doesn't feel good. And then you have a guy who's high testosterone. He's at the beach with his shirt off, playing volleyball, going for a run. He feels great. He's then getting more vitamin D than the other guy. This is clearly established. We have all of the notes, all the references in the notes. Stop giving vitamin D thinking it moves the needle on testosterone. It doesn't. The evidence is clear about this. And so likewise, magnesium, zinc, boron, there's studies showing that boron raises testosterone by 10%. Guess what? 10% is still within the lab variance. So still, what are you doing with these? And of course, we saw no change. He's still somewhere around 10. And all of these he's stacking. By the way, he's doing everything he did before. He's continuing to do.
We poked this poor man so many times.
Yeah, we did. Week 7 to 8, we stepped it up to the herbals, ashwagandha, fenugreek, maca, damiana. There's evidence on all of these moving testosterone by 10% of a group. But when you move a group, you didn't move every individual 10%. Some of them went up more, some of them went up less. On an individual basis, you can't give somebody ashwagandha and retest and think you're going to see a big difference. 11.5, great. We think that we're seeing a change. So then the following weeks 9, I forgot to change this. This is weeks 9 to 10. We added Fedoja, Tonkat, Tribulus, as well as continuing everything he was doing before. And nope, false alarm. He didn't actually go up to 11.5, false win.
We were like, oh, it's working.
Yeah, we're getting somewhere. And then the following week, no.
Balloon
still. So then weeks 13 to 17, we switched him to clomiphene citrate. That's an oral selective estrogen receptor modulator. We don't have time to get into the biochemistry.
I would have loved to talk about this, but no.
We'll save that for a later course. That should raise testosterone 2 to 2.5 times. It does. We've seen it many, many a time. The longer you're on it, the less good. You don't feel as good as you did at the beginning. And there are some adverse effects. One of them.
We're talking about it. Move on.
Yeah. Okay. Anyway, we'll cover this another time. Clomiphene should, in 1 in 4 guys, should be a reboot to their physiology. That 6 months later, they're above 10. That was not the case with him. He actually had to discontinue because he felt really crummy on it. So then week 30, give it a while, and he on our recommendation, he consulted with his medical doctor to inquire about testosterone cypionate. Or testosterone in general. He was prescribed testosterone cypionate, 50 milligrams, twice weekly. He was also given HCG as a low dose to keep the testicles from atrophying. And his testosterone went up wonderfully, went up into 18.6. So that worked. Now we had him on that for about 6 months. He didn't feel any improvement in his symptoms. We discontinued. We support him through a brief post-cycle therapy, a topic for another day. But he went on a vacation to Ireland. He was there for a month. He felt great. He always seems to feel better when he's traveling and on a vacation and de-stressed somewhere connected with his family and in nature. So was this testosterone all along that was the problem? No, because we lifted it. He didn't feel better. We took him off it. He went on a vacation. He felt better. So another case of mythology of testosterone here. Case 3. I'll try to rip through this one.
Yeah, I love this one so much.
You cover this.
No, this is your patient.
Okay. This was a cybersecurity officer. He's 39 years old. He has ADHD, for which he's medicated with Vyvanse. He's subfertile. They've been trying to conceive for 9 months. And it makes sense because he was a past anabolic androgenic steroid user and a TRT user. He reports having never been the same since. His mood, his erectile function, his semen parameters, of course, were low normal limit. All this is likely related to his past use. His body fat percentage was good, 22%. So we ran a baseline for him. Of course, it was under perfect conditions. He was highly insulin sensitive. So good. This is his true baseline. He's a 10 for testosterone. Okay, weeks 1 to 12, we supported him with a couple of different things. For mood, we supported him with saffron, ashwagandha, SAMe, magnesium, strictly for neurotransmitter support. And there's some placebo effect within that, but some evidence showing improvement in mood. So sure, put him on that in the background for the background benefit. But the main driver here of change for his erectile function, for his semen parameters, was the gonadal support. We put him on HCG 1250 twice a week and rotating mitochondrial formulas for the semen quality. And of course, his luteinizing hormone completely bottomed out, as you'd expect, because we're stimulating the testicles via HCG, not via LH. And then his testosterone floated up to about 18. So that's great. Week 14, he went on a holiday to Dubai. He left his HCG at home, so he wasn't on it for a little while. When he came back, his testosterone was a 2.6, and he freaked out, calling our office, trying to get in touch, because what the heck, why is my testosterone so low? Every androgenic intervention, anything that moves the needle up on testosterone, when you stop it, will rebound to go below your baseline and then slowly come back up. Don't freak out. This is normal. He just happened to catch just within 10 days post HCG. That was the pits of his testosterone post therapy. The half-lives vary. We've put a link in the references, but there's ethnicity, dosing, length of treatment, whether it's anabolic androgenic steroids, TRT, gonadal options. The half-lives vary a lot, but don't freak out when you send a guy or a guy goes to the lab with your lab rec just after treatment, because it is going to rebound.
Give us 2 more minutes, okay?
Okay, real quick. So week 16 on no treatment, just letting him naturally rebound. His latex cell production self-recovered as expected. Week 17, they found out they were pregnant. So while he was in Dubai, already having been stimulated, they became pregnant. And so we opted to revisit testosterone therapy again, testosterone support next year, because mission accomplished. He's happy that that they were able to get pregnant. And this testosterone of a 10, he was already feeling better with the mood support and with the elation of the news. And so we'll look at this again in a year. Wrap up.
Oh my God, we actually almost did it.
Almost.
So this is just a review. The cases are all reflective of this. Think about this. We'll maybe remake it to be a little bit more reflective of how it should be on the chart, but think about this. Treat the person for what's going on with them. Don't use testosterone as the be-all and end-all. If it is meaningful, repeat it in the correct conditions, identify if it's a true problem for them, and then work that into their case, whatever their original underlying problem is, with testosterone support on top of that.
We've laid this graph out in another way. So, Doc, why is my T low?
Is it actually low, or do you just wish it was higher? Is it a lab is not a measure of worth or manliness. This is a very, very important conversation that we need to have, because it takes a lot of men out of this sort of game that they're in with themselves and with society. Are there signs and symptoms? We need to know which ones are strongly linked to testosterone as both a diagnosis, a need for test, and then for warranting treatment, and then will they improve on treatment? Find the reason that the other reasons that could be the culprits for this problem as well, not just relying on testosterone, and then make a game plan. Make sure this person is as fit as they possibly can be, getting their body fat percentage down. You can use other agents to help that. Make sure their habits are as well as they can be, because this is all about decades from now, not 3 weeks from now. And you can use TRT or other testosterone increasing treatments, but they're not cures, and there are some pros and cons associated with them, which are very nuanced.
So much more to cover on another day. So we've set up a page on our website, gravityhealthclinics.com. You'll get up to the For Doctors tab, and you'll see a newsletter form there that you can put in your name and your email. We'll let you know when we have a more comprehensive testosterone interventions and deeper dive about all of these things available. But there's so much more to say. I feel like we're just barely skimming the surface here. And so add your email. We'll let you know when that material is ready.
And we also know, we've done this many times now, not on testosterone, but on many other topics over the last couple of years, that there's always so many questions. We have created an ND to ND consult that you can book in. We've done this many times now. It's gone very, very well. To honor both our time, but also to honor your questions, especially if they're clinical cases that you need help on. We are happy to help. So please take advantage of that too.
Fantastic.
Thanks.
Thank you so much. I want to say thank you to everyone that's attended and registered to this webinar. You will be getting a recording of this at the end, just to allow us about a week to get that to you.
Yes.
I wanted to thank Dr. Bobby Parmar and Dr. Paul Maximus for a wonderful job of finally doing our first male conversation on testosterone. I think this has been wonderful. I know there was a list of questions that were done in the chat. We will email those to you, Bobby and Paul, and perhaps maybe if you can take a moment, you can give us some answers, and we will get back to the people that have asked them in a follow-up in a week. And again, I want to thank everybody that's here. Thank you again, and we really appreciate for all your support and time. And have yourselves a wonderful day. Thank you so much.
Thank you.